Let's start off with hub introductions. I'm Dr. Bob Seiss, an addiction psychiatrist and chief medical officer at Frontier Psychiatry. Thrilled to be back for our first Echo Clinic of June. Amber, if you'd please take it away.
Amber Rogers with Mountain Pacific Quality Health, and I'm here to help facilitate with chat box and questions and stuff.
Excellent. Mary?
Hi, Mary Argonis from Mountain Pacific Quality Health, IT support. Thank you.
Excellent. Who else do we have on from the hub?
Jessica, Mountain Pacific Quality Health, and I'm here to help Amber with the chat and those things.
Wonderful. And I'm looking for Malcolm Horn. I don't see her connected yet.
I'm here.
Oh, excellent. Sorry, missed you. You're here. There you are.
I'm here. I just joined. I was like a minute late.
Welcome.
Thank you.
If you wouldn't mind doing just a very succinct introduction.
Sure. Malcolm Horn, Director of Mental Health Services at Rimrock. I'm an LCSW and MAC. I supervise a lot of dual license counselors working on their license. I carry caseload. I teach a couple classes at MSUB, and I definitely have drank the Echo Kool-Aid. So I'm really glad to be on an Echo. So thank you for having me.
So glad you're here. And we have some people chiming in on chat. Julie Cooper, with no video or audio, but you are able to hear us, which is a good thing. Nurse MDS coordinator at St. John's Living Center. Welcome, Julie. If others would like to either, and let's leave this up to folks, if you could either type in who you are, your name, title, where you're connecting from, or if you'd like to take it away right now, please don't be shy. Alyssa Dransfield, Social Services Director in Colorado, welcome.
Hi, everyone. I'm Hope Kratz. I am the Clinical Director at Menida Healthcare Network.
Thanks for joining us, Hope. It looks like we have Glynis Almonte, a nurse from Guam. Welcome. Kimberly Hill, Community Outreach Coordinator, Idaho, Montana, Ideal Option. Welcome. Don Runyon, Ombudsman in Cheyenne. Minette Wong, Project Support at Mount Pacific. And Gavin Wisdom from Partnership for Children, Strengthening Families in Missoula. Sharon Woodward, Director of Social Services in Juneau. And Don Marie Thacker, Regional Ombudsman from Riverton, Wyoming. Jennifer Kien, a nurse, complex care for Logan Health, Kalispell, Montana. Hafi Adai, hello from Guam. All right. Please let me know if I missed anyone. Let's get started with our discussion. Amber, would you confirm that we're full screen?
You're showing, there you go. Perfect.
Excellent. So very, very timely topic. We'll be discussing opioid use disorder, treatment of opioid use disorder, and what's changed in the epidemiology of opioid abuse in the midst of COVID-19. For continuing education, please sign in using a link provided in the chat box. Amber has been incredibly generous insofar as being proactive in registering people. We're going to put a stop to that so as not to reinforce and have people actually sign in using the link in the chat box if they wish to have credit. It's 1 credit hour for providers as well as nurses. Easy to get. Click the link and you're there. Disclosures. Dr. Arzubi, Dr. Hosseini Gomi, and myself are owners and co-founders of Frontier Psychiatry. Dr. Hosseini Gomi, as well as Amber, do have the financial interests listed here. The nurse planner will ensure the program remains free of bias. Announcements.
This is Amber. I just wanted to let everybody know again to reinforce the chat or the attendance link, but also in our last meeting, we discussed this Next Distro, and it is a free resource to anonymously, somewhat anonymously request naloxone to be shipped to your door. This is extremely helpful in smaller towns. It is available in Montana and Hawaii, or is it Alaska? Now I can't remember. Only. It is not available in Wyoming until somebody decides that they would like to be, be the hub for that. So in Montana, it's the Missoula AIDS Alliance that does that work. And I'm putting the link in the chat box so you can share this with your patients, and it's free. And if we are talking about the increase in overdoses, it will be super helpful for folks.
Thank you, Amber. Very pertinent. And hopefully we can discuss that further here in just a moment. We do have a case, so let's jump straight to it. A special thanks to Dr. Andrew Saxon. Dr. Hosseini Gomi and myself trained under Dr. Saxon. He is one of the professors at the University of Washington, addiction psychiatry residency, as well as the fellowship where I trained. He's published over 400 articles, cited over 16,000 times, is the section editor for up-to-date sections on opioid and alcohol use disorders. He's also incredibly modest, pleasure to work with. Very, very thankful that he was able to provide some of the evidence we're going to be presenting today. We'll appreciate the epidemiology of opioid use disorder and recent trends, in particular focus on what's happened in the last 12 to 16 months in the midst of COVID-19. We'll review the evidence for medication-assisted treatment in relation to its impact on the morbidity and mortality associated with opioid abuse, and acknowledge evidence-based psychosocial interventions for treating opioid use disorder. When we discuss opioids, we're referring to natural or synthetic compounds that bind to opioid receptors to reduce feelings of pain. Prescription opioids are intended to treat acute pain, like post-op, as well as pain associated with cancer treatment, palliative care, and end-of-life care. Opioids reduce the perception of pain, but can also cause drowsiness, confusion, euphoria, GI symptoms. At high doses, they result in respiratory depression, in extreme cases, death. If I could remind everyone to mute, unless you're actively participating. I do hear a tiny bit of background noise. Thank you. Prescription pain relievers include oxycodone, hydrocodone, codeine, and morphine. Synthetic opioids include heroin, fentanyl, methadone, pethidine, tramadol, as well as carfentanil. Here on the right, you can see a smidgen of fentanyl beside a penny to give a scale. This would be a fatal overdose for most people. Fentanyl is 50 times more potent than heroin and 100 times more potent than morphine. This is a great visual provided by the CDC and allows us to appreciate what is driving this overall trend in opioid overdose deaths. It's essentially three waves. The first started around 1999. It was a boom in the availability of prescription opioids, leading to a resulting increase in overdose deaths. Then come 2010, we saw a boom in cheap heroin, in particular, black tar heroin, and a steady rise in heroin overdose deaths. And then finally, really starting in 2013, saw a boom in synthetic opioids, especially fentanyl, that has been raging since then, driving up the overall death toll even more. From 2002 to 2017, broad strokes summarizing what we saw in that visual, there's a 22-fold increase in the number of deaths involving fentanyl, a 7-fold increase in the number of deaths involving heroin. Over 72,000 Americans died from opioid overdoses in 2017. This is a 2-fold increase from a decade prior, with fentanyl and its analogs associated with 30,000 overdose deaths in 2017, heroin being involved in almost 16,000, and prescription painkillers were involved in almost 15,000 deaths from overdose. Then came COVID-19. Things have gotten a lot worse. This last year, we saw over 90,000 deaths in the United States from opioid overdose. It's the highest level ever recorded, likely due to several factors that worsened in the midst of COVID-19. Increased unemployment, increased social isolation, people are overall more stressed and have less access to care. If we look across the US in the most recent year of data, we see a 30% increase in opioid overdose deaths, and opioid abuse specifically increasing by 30%. If you focus in on, say, Wyoming and California, you can see it's especially bad. The darker colors are a bigger increase. Whereas South Dakota, remarkably, and Alaska, at least per the recorded data, didn't fare as badly. Here's the overall trend, mapping out 5 years, really focusing in on this last year. Look at that abrupt increase in opioid overdose deaths. If we focus on Alaska, we see the last year of data isn't that much of a deviation from the overall trend, up and down, somewhere around 125 deaths a year. Whereas in Wyoming, a big boom, it's the same x-axis for this bottom graph, big boom in the last year in opioid overdose deaths. Slowly increase for Hawaii as well as Montana, although not as bad as we saw in Wyoming, at least not proportionally. Some compelling data about opioid misuse. 25% of patients who are prescribed opioids for chronic pain end up misusing them. Again, recall that really opioids are intended for treatment of acute pain, not chronic. So this isn't that surprising, yet still a lot of patients end up on chronic opioid pain med regimens. 10% of them will develop an opioid use disorder. 5% who misuse prescription opioids ultimately transition to heroin, really making prescription opioids the current gateway to heroin, with 80% of heroin users first misusing prescription opioids. Do you want to acknowledge a patient population that has been very compelling to work with? Cancer patients. When I was an addiction psychiatry fellow, I spent over 3 months at the Seattle Cancer Care Alliance treating cancer patients with opioid use disorder. It's no surprise this happens when we really stop for a moment and reflect on the dynamics at play impacting these patients. Opioid pain medication is really the mainstay of pain management and cancer care. And the main focus for these patients is treating the cancer. So it's no wonder that their opioid pain regimens go fairly under scrutinized, and there's not a focus on keeping the overall doses in the moderate range. Many experience the iatrogenic effect of being on opioid analgesia, with new persistent opioid use in over 10% of cancer patients who are opioid naive before they started cancer care. Many think it's harder to treat than the underlying cancer, and based on what I saw firsthand in that clinic, I would tend to agree. And of course, cancer patients who endure a stressful treatment course oftentimes end up even worse off. In one study from 2017, they saw patients who received adjuvant chemotherapy. So chemotherapy, in addition to, say, surgery, had a twofold higher risk of persistent opioid use in comparison to those who didn't receive the adjuvant chemotherapy. From the bad news to the somewhat better, let's talk about treatment. This is, I think, a very depictive image from the Pew Charitable Trust that compares the 3 different FDA-approved forms of medication-assisted treatment for opioid use disorder. Oh, I'll go back one. Methadone, which is an agonist of mu opioid receptors, binding them fairly tightly and fully activating them, a full agonist, versus buprenorphine, which, while it has a high affinity for mu opioid receptors, only partially activates them. And then lastly, naltrexone is a mu opioid receptor antagonist. It blocks mu opioid receptors. Let's start off with methadone. Tried and true, it has been around by far and away the longest of these 3 forms of medication-assisted treatment. It was first rendered during World War II in Germany in 1937 by a German chemist, as the Germans at that time did not have ready access to natural opioids. So they had to synthesize them. Methadone is a synthetic opioid. has a very, very long half-life, allowing it to prevent withdrawal symptoms for over a day, reducing craving for opioids. It also, because it maintains tolerance, reduces potential euphoric effects that people could otherwise get from abusing opioids. Available oral solution as well as a tablet and injectable solution. We generally use the oral solution in opioid treatment programs. Because of the exceptionally long half-life and the fact that it is a full mu opioid receptor agonist, there is significant risk of respiratory depression after each dose. And because of this risk, the DEA fortunately requires that methadone, when it's being used to treat opioid use disorder, be dispensed through an opioid treatment program, as there is that risk of respiratory depression, in extreme cases, death from overdose. Let's look at the evidence as to why medication-assisted treatment in general, and specifically methadone, is so compelling. This comes from a study done in 1981 by Gunn and Granblach in Sweden. It's a study that would never be duplicated today, as no IRB would ever sign off on it, and we're about to see why. They took a cohort of 34 patients and randomized them, 17 to receive methadone for 2 years. The control group, no methadone. All 34 patients did receive a psychosocial intervention, which, as I recall, was chemical dependency counseling, as well as mutual help group, a 12-step group of sorts. What happened after the 2 years? In the treatment arm, 12 out of the 17 patients remained abstinent from opioids of abuse. And there were no deaths, no significant morbidity. Let's look at the control arm. At the end of those 2 years, 2 were dead. 1 had sustained sepsis, 1 sepsis as well as endocarditis, 1 a leg amputation. All of these were complications from return to opioid abuse, as were the deaths. And there were 2 people who were incarcerated due to drug-related crimes. Clearly, when we think about reducing morbidity, mortality, as well as social complications from use, this is all too compelling, so much so that we can never duplicate this study, as it would be very unethical not to give people access to medication-assisted treatment. Buprenorphine. Again, it is a partial mu opioid receptor agonist, super high affinity for the receptor with a prolonged duration of action, suppressing withdrawal for 1 to 2 days. It fortunately has a ceiling effect at high doses, which we'll discuss more in just a moment. To prescribe in the outpatient setting, a provider must be X-waivered, or as of just about a month ago, SAMHSA, per Biden's direction, is now allowing providers to proceed to prescribe to up to 30 patients without an X-waiver, so long as they complete notice of intent. It's a form you can access on the SAMHSA website. Buprenorphine is available both sublingually as well as subcutaneously. The subcutaneous form is a long-acting injectable, Sublocade. Sublingual form, most often we're talking about Suboxone, which is buprenorphine, active ingredient, plus naloxone. The naloxone is not bioavailable. It's there to prevent abuse, specifically to prevent patients from trying to inject the buprenorphine, because with the naloxone in there, given it is a reversal agent, if they were to try and inject Suboxone, somehow strip it and get it into a solution and inject it, they would be provoking withdrawal right away. So it's kind of a big deterrent. When we think about the ceiling effect of buprenorphine, what's worth again emphasizing, it is a partial mu opioid receptor agonist, meaning that it does not activate the mu opioid receptor all the way. And for that very reason, we don't see absolute respiratory depression. Here on the left, we have fentanyl, which is a very, very potent full mu opioid receptor agonist. On the right, buprenorphine. X-axes are the respective doses increasing from left to right of fentanyl and buprenorphine. On the y-axis, we have ventilation. Essentially, think about it as respiratory drive. Lower down, less respiratory drive. Sure enough, You give a patient a high enough dose of fentanyl, you're going to see respiratory depression to the point of apnea, and without intervention, death. Whereas with buprenorphine, you see a plateau. You only see partial respiratory depression. This is what makes buprenorphine so safe, and why, at least in comparison to methadone, there is more access and it can be more readily prescribed in the outpatient setting. There is similar data for buprenorphine insofar as thinking about the impact and acknowledging what it can do to decrease mortality from opioid abuse. In another Swedish study, this time done in 2003 by Kako and co-authors, they were actually targeting an assessment of the functional impact of buprenorphine, how it would help folks who have opioid use disorder return to function. They unintentionally found this really compelling outcome. So here, the total N was 40 patients randomized to detox and receive placebo plus psychosocial intervention, whereas the other arm of the study got psychosocial intervention plus buprenorphine. Followed up 1 year later. In the placebo arm, 20% were dead, whereas in the buprenorphine arm, there was 100% survival. Again, very compelling. Naltrexone. We need to emphasize here what makes naltrexone stand out in comparison to the two other FDA-approved forms of medication-assisted treatment. Naltrexone is a mu opioid receptor blocker. It also competitively antagonizes kappa and to a lesser extent delta opioid receptors in addition to the mu opioid receptor. Because it is an antagonist, you, by using this instead of, say, methadone or buprenorphine, you can avoid some of the bothersome side effects associated with opioids, fatigue and hypogonadism. It does require detox from opioids, as if you give it too soon and someone still has opioids in her or his system, you can induce withdrawal. And it's, of course, contraindicated for patients if they need opioid analgesia. The evidence vastly favors the long-acting injectable form, IM naltrexone, which is a once a month, 380 milligram injection in the gluteus. Whereas the oral form, a lot of patients struggle with adherence. Based on a retrospective cohort analysis of over 99,000 patients, approaching 100,000 with opioid use disorder, authors saw that long-acting injectable naltrexone was as effective as buprenorphine in preventing opioid overdoses and reducing mortality. When compared head-to-head with Suboxone in a randomized clinical non-inferiority trial, the long-acting injectable naltrexone was equally efficacious and safe. Can't emphasize enough that the evidence vastly favors combining medication-assisted treatment with psychosocial interventions over MAT alone. We get the best outcomes when, in addition to MAT, we emphasize weekly chemical dependence counseling, attendance at 12-step meetings several times per week, or if patients prefer, some other form of mutual help group, as well as a targeted psychosocial intervention, be it cognitive behavioral therapy, contingency management, motivational interviewing, community reinforcement approach, or combined behavioral intervention. And many experts favor matching interventions based on how patients present within the readiness to change framework. Specifically for those who are pre-contemplative or perhaps contemplative of change, motivational interviewing or contingency management appears to work the best. Whereas for those in the preparation or action stages, CBT appears to have the greatest therapeutic value. Additionally, for patients who are ambivalent about attending a mutual help group, 12-step facilitation can make a big difference insofar as engaging them and getting them to attend the group and appreciate benefit. If you're going to focus in on any of this content, please let it be the next two slides. Let's close with some takeaways. Pre-COVID-19, the opioid epidemic was already raging, with over 72,000 Americans dead in 2017 from opioid overdoses. That was a twofold increase from 1 decade prior, with synthetic opioids, primarily fentanyl, its analogs, driving some of the more recent increases. Then along came COVID, and from October 2019 to a year later, a 30% increase in opioid overdose deaths, to the point that now over 90,000 Americans are dying each year from opioid overdose deaths. The most effective treatment is combining medication-assisted treatment with psychosocial interventions. The recognized and effective forms of medication-assisted treatment are methadone, which is a full agonist and requires enrollment in an opioid treatment program if people are getting it to treat opioid use disorder. Suboxone, which as a partial agonist is safer. Again, respiratory depression plateaus at higher doses, so we can give this in more clinical settings. Versus IM naltrexone, which is an antagonist. It blocks opioid receptors, equally efficacious to buprenorphine, though is contraindicated in patients who've yet to detox or require opioid analgesia. And I'll stop the share. All right.
So in the chat, Dr. Seiss, we did have a little mini case from Dawn Runyon. And we'll open, if you can unmute yourself, Dawn, and just kind of talk to Dr. Seiss.
A woman who's 83 years old, and she's been on opioids for a long time. She doesn't abuse them, and they're the only thing that has to date worked for her to at all resolve or relieve her pain. She doesn't abuse them. She hasn't had big increases in dosage. I don't know, what do you think about that? She doesn't, that's the only thing that works. She doesn't abuse them.
Yeah.
Do you think that she needs to do something else? I mean, do you think any opioid use in a long-term setting is bad?
Don, thanks so much for bringing up this example. I think it's really compelling as you're identifying someone with physiological opioid dependence. It's really important to emphasize that we know conclusively it only takes the vast majority of people 5 weeks to develop physiological dependence to opioids. What we're referring to is people having a real physical shift in the equilibrium of their opioid receptors in response to taking opioids on a regular basis. And the individual you mentioned, as I recall, 83-year-old woman who's been on this chronic opioid pain medication regimen, now longstanding, and she really identifies it as the only thing that relieves her pain. She's not abusing the medication insofar as unilaterally increasing the dose. There's no evidence that she's running out of the medication early or somehow taking it in any way other than ingesting it. She's not injecting it or anything like that. So I think it's worth emphasizing that based on what you shared with us, while we have evidence of physiological opioid dependence, when we think about diagnosing opioid use disorder, while it does require that component, along with it, we're looking for functional impairment. Specifically, does it get in the way of her ability to work? Is she continuing to use opioids, even though her physician is telling her she needs to taper off because in some way it's undermining her overall physical health in a real emergent way? Is she failing to perform key things in other parts of her life, other domains, like be it with her family, friends, church, whatnot? That's what we look for insofar as making the DSM-5 diagnosis of opioid use disorder. And if we really want to be correct and adhere to the DEA protocol, we need to render the diagnosis of opioid use disorder, at least within the space of psychiatry, before we proceed to prescribe medication-assisted treatment. If we fail to do so, we could risk being out of the scope of practice that's intended. Sure enough, you can use buprenorphine to treat pain, and it's a lot safer for the reason we acknowledged. It has that plateau effect when you think about how it impacts respiratory depression, whereas on full opioid receptor agonist, oxycodone, Dilaudid, what have you, people can overdose and die, but that would be more within the domain of primary care or a pain clinic to prescribe buprenorphine to target pain, if that makes sense.
It does. Dependence is necessary when, I mean, when it's relief of pain, of course, there's going to be a dependence, because if there wasn't, then it wouldn't work in the long term. I don't know if I'm saying this right.
I think it's a very common concern we hear a lot, and very often, especially when we work with patients. We know conclusively there are way more sustainable, safer forms of pain treatment if you're thinking about managing chronic pain. Opioids are really intended to treat acute pain. In many ways, we were sold a false promise by the pharmaceutical industry throughout the 90s and early 2000s. And that's one of the reasons this epidemic began. And now we're doing what we can to educate people. And part of what we're emphasizing is when people receive opioids for pain management, to keep the course of treatment very well circumscribed, ideally, to max 3 to 4 weeks. What you see with chronic, long-standing use of opioids is hyperalgesia. So people get overly sensitized to pain because the mu-opioid receptors shift insofar as how they respond. And people need higher and higher doses of opioids to get the same effect, even if they're just targeting pain over time.
Okay. All right, thank you.
Again, very, very compelling scenario. Thanks, Don.
Welcome.
Alyssa, it looks like you have some questions.
Yes, I do. Can you hear me?
Yes.
Okay, great. Okay, so yes, I do have 2 questions. So if you are starting a patient, resident, client, whichever, say, they have, they're pretty substantial with the opiate use disorder, as in, they're in a treatment like intensive residential treatment or one of the higher levels of treatment.
Alyssa, so sorry to interrupt. Would you be able to turn on your camera?
Oh, yes.
Thank you. And if we can have more folks, please turn on their cameras. I'm staring at a lot of black screens. Okay, awesome. Please.
Hello. So my question is if we're having a population and they are in, they are on something like methadone to help them and they're in intensive residential type of treatment. So one of the highest forms of treatment that we have, and we are really trying to pair, methadone, like we're saying, with treatment, because that's one of the most effective. Would you then also agree with tapering off of them as they're going down the continuum of treatment? So if they're, in intensive residential treatment, then they go to IOP and WOP, and is that kind of how a taper scale should look like?
We're talking about tapering the psychosocial intervention?
Yes.
Yeah, potentially. Oftentimes it's most immediately a function of what's available.
Okay.
What we're seeing in the community is access even to IOP is sometimes a luxury. I think the ideal plan would be a gradual taper to see how the patient is doing in treatment team. Ideally, it's going to be the LAC, someone who has eyes on the patient in group, in addition to the provider, as well as ideally the overall program coordinator discussing the cohort of patients, talking about how they're doing, looking at the data when it comes to group attendance, how that person's showing for appointments, looking at the urine toxicology.
Mm-hmm.
That's what I saw firsthand when I worked 1 year at the Seattle VA Addiction Treatment Center. You had that robust team-based approach in which it was kind of all eyes on the data and focusing in particular on patients who are struggling and talking through those cases. We had the chance to say, okay, let's give them the benefit of another month of intensive outpatient before transition them off. So yes, totally agree with more gradual taper is best. Oftentimes though, logistics kind of determine what we can't do.
Okay, and then my second question is when somebody is on, methadone and they're fresh into sobriety and trying these treatments, but they, stop taking the treatments, they go off of it and relapse. Are you seeing any higher overdoses because they are thinking they need to use more or the same amount to get the same effect, since some of those are antagonists and they're blocking it anyway? I'm just wondering.
So yeah, to kind of to focus very deliberately on the different forms of medication-assisted treatments, which can in some ways seem nuanced, but it's really important in particular for this concern, tolerance. So one compelling thing about methadone, and to a lesser extent buprenorphine, for methadone, it is a full mu-opioid receptor agonist. So it's binding those receptors and fully activating them. As such, you are preserving tolerance. So if someone goes off a methadone and in rapid succession is using, say, heroin, in theory, they would have a fair amount of their tolerance preserved. Now, if they're entirely free from methadone for a few weeks and then see a return to use, and they try and go back to using that 1 gram of heroin, say they were injecting before they started treatment, then you could be in dire straits, because sure enough, it will take less opioid to induce respiratory depression and kill somebody. And that's just what we've seen. One of the first patients I had die on service, it was just that scenario. She was getting discharged from the psychiatric center at University of Washington Harborview Medical Center. She refused buprenorphine. And sure enough, there was a highly potent batch of heroin on the streets of Seattle that week, laced with fentanyl. She overdosed and died.
Okay. That's what I was
So I think it's a really pertinent concern. With buprenorphine, partial agonists think around 40% of the kind of full scale, whereas methadone is 100%. So you do have some tolerance preserved. It's not the same. Whereas naltrexone, because it's an antagonist, you're going to have some blockade and protective effect to a certain point. But if people keep using enough opioid on top of it, they will overcome it, go into respiratory depression and die.
Okay. Thank you. That makes sense.
Great question. Okay, and Julie would like to see the very last slide again. We will be sure to share these. I'll pull it up. And Julie, it was this slide? Okay. So I am on my laptop and don't have the best view of the chat. Let's see.
Yes, that's the correct one.
Great.
So,
Okay. All right. So we do have a case. Certainly want to leave time for that. Do we have any questions? Maybe we'll give like a quick 60 seconds. This is great participation. Awesome. People have their cameras on. Any takers? Don't all speak at once.
well, I don't have a question per se, but as an ex-oncology nurse back in the early 90s, when we were told that, pain medication just was eaten up by, and there wasn't going to be any problems, that statistic about long-term opioid use in cancer patients is really sad.
It's brutal because, to have someone survive oftentimes a dire prognosis, especially at like a quaternary level of care that you get at Seattle Cancer Care Alliance. And then you're talking about the diagnosis of opioid use disorder. These are people who've been through a lot, and you can't help but feel even more empathy in some of those scenarios. All right. Well, if we could have nurse practitioner Megan Lehman take it away with a very compelling case. I'll stop the screen share.
All right. So I have a patient who's a 39-year-old woman with opioid use disorder. She presented to clinic 6 or 8 weeks ago, very disheveled, very guarded, living in her car, unemployed, doesn't have custody of her children. She presented telling me that she wants to get her life back on track. She wants to stop substances. She's had a long history of mood instability, never been hospitalized for any psychiatric issue. She has had a couple suicide attempts. She continued to tell me she can't believe she's let her life get this far, losing her kids and her house and her job. She felt like she's at rock bottom. She reported she was taking about 100 milligrams of oxycodone daily from the street. She also reported her longest period of abstinence in the last couple years was maybe a week. She denied alcohol use, states she uses cannabis rarely, and denied any other drug abuse. So we did a bunch of motivational interviewing, and she stated that her motivation was 10 out of 10 to stop her substances because she wants her kids back and her life back. She does have a history of PTSD. One of her children physically assaulted her. So she met diagnostic criteria for opioid use disorder and was started on 8 milligrams of Suboxone sublingually each day. So as time went on, increased it to 12 milligrams of Suboxone daily, which is what she's currently taking now. So how she's progressed, she's reported to every appointment every week. She's always submitted her urine drug screen on time. She currently is working with the mental health center to help her apply for college. She started a job as a waitress, and she's currently living with a friend. So I just wanted to kind of go over some of her urine drug screen results over the last couple of weeks. So her initial drug screen tested positive for oxycodone, which we knew, and then methamphetamine and cannabis. And then week 2, her norbuprenorphine to buprenorphine ratio was 1,000 to 490. And we'd like to see that metabolite in the urine at like a 2-to-1 ratio. So that was pretty perfect, 1,000 to 490. She also tested positive for methamphetamine and THC. So subsequent week, the norbuprenorphine to buprenorphine ratio was 198 over 113. So again, that's pretty good ratio of 2-to-1. She did have THC in her system, but no meth. 4th week, she had her norbuprenorphine to buprenorphine ratio was 587 to 330. So again, pretty much 2-to-1. She had amphetamine, methamphetamine, and cannabis. So as of last week, her norbuprenorphine to buprenorphine ratio was 778 over 184. That ratio wasn't 2-to-1, which makes me wonder if she ran out early or skipped the day, skipped the dose the day she gave urine. The level of norbuprenorphine is good to indicate that she is taking it. And then her methamphetamine level was 66,000, and cannabis was positive as well. So she's a good example of a patient who has continued to abstain from the opioids with the buprenorphine, but she's still currently using other substances. So this is a good case to discuss what we would target moving forward and what would be a good plan of care for her.
Excellent, Megan. Thank you so much. Very compelling case. And I'll do my best to summarize, and please keep me honest. A 39-year-old lady who meets diagnostic criteria for opioid use disorder, as well as PTSD and depression. A lot of psychosocial distress in the midst of her use. Also abusing methamphetamine, as well as cannabis. Is adhering to her treatment plan insofar as making 2 appointments, leaving UTOX as requested, and you're in many ways kind of asking what should you target as the provider, acknowledging, okay, here's opioid use disorder, perhaps in one kind of discrete domain. If we look at, hey, is the medication-assisted treatment having its intended benefit? Specifically, is the patient abusing opioids? Based on the available evidence and what she's telling you, it sounds like yes. It's a success, and she's not using opioids.
Right.
Whereas you're concerned about her abusing methamphetamine. And I know, based on what you mentioned to me just yesterday when we were talking about this case, that it looks like both the methamphetamine as well as amphetamine levels, the nice thing about getting a quantitative UTOX, it will give you an actual measurement of where the meth use is. It is increasing over time. And so what's up with that?
Right. It's continuing to increase a lot.
And so this is challenging. It prompts us to think about what are our targets and how are we practicing? Are we demanding abstinence? There are some treatment programs that would perhaps urge kind of a transition of care if a patient continues to abuse something like methamphetamine, even if they're abstaining from opioids, and seeing benefit from medication-assisted treatment in that way. Can acknowledge what kind of psychosocial treatment is she getting? Excellent question, Melissa.
She does have counseling visits weekly. I would say she probably shows up to 2 a month.
Okay. So insofar as meeting with the LAC at the mental health center,
yeah,
she's making it maybe to half the appointments, so not great adherence.
Right.
So, and it looks like Don is asking about other opioids. What does the quantitative urine drug screen show us? I think it was
just oxycodone. That was it.
Yep. Okay.
Yep.
So that would give us, we're getting some great contribution. So, hey, how about people please unmute, and starting with Dr. Horn, please take it away.
Thank you. I would definitely want to ask her first. Hey, your UAs were positive for X, Y, and Z. I mean, it's crazy, but we've had patients that are like, what? I didn't use anything. And it's like, okay, that's interesting, right? Like what, tell me more about that, because your UA is saying something very different. Like what's happening there? Or do they say, yeah, I've been really struggling. I'm stressed out. I'm overwhelmed and I'm using X, Y, and Z to get through it. Great. That gives me a great therapeutic thing to go with. Okay. You're feeling overwhelmed and stressed and you're still using a substance and you know, you're not going to use the opiate. So I'm going for something else. We need to look at coping tools. Do we need to then do some real targeted coping tools to whatever it is that's motivating that use, right? And is it, what is it? And with the trauma background, it wouldn't surprise me if, without knowing the whole story, I mean, we see patients that they get sober-ish, and all the trauma that they've been repressed comes out, and then they got to go do something. So then would we look at a real targeted, like EMDR or some type of other therapy to help her? And if she's motivated, I mean, the big question of abstinence-based versus harm reduction, if she's motivated to say, I want to get better, okay, we'll work with that, right? But if she's like, nope, I'm going to continue to use the marijuana, it's going to be recreational anyway, it's legal, then we're going to go, well, let's talk about your motivation. Like, what do you want long-term? And is that going to fit what you need long-term? So that's kind of where I would go with her, to see what are her needs and can we help her meet those needs in a healthy way?
I like that, Dr. Horn, very much trying to meet the patient where she's at insofar as her willingness to change and acknowledge a specific type of substance abuse as a problem.
And it might be scary to change. I mean, as much as they might say, I want change, I want to get better, that is still terrifying for a lot of them. And so really recognizing that, yeah, and given so she lost her kids, she's had some trauma just with that. So that's got to be difficult to work through. How can we help you work through that?
She's gone through a lot and has a lot at stake.
Yeah, absolutely.
It looks like Melissa Bates was talking about group counseling being recommended over individual counseling. Melissa, please tell us more.
I mean, I don't know what's available where you live, and I know sometimes it's hard to get groups, and most people will initially not want to go to groups. And everybody wants to do individual counseling because it seems less scary to talk to one person than 20. But the standard and the evidence is that people benefit from other people that have been through similar experiences. And once they try it, whether it's qualified group therapy or even 12-step stuff, I mean, there's a reason that 12-step meetings have been around for 100 years. They work and you can't beat the price. I think there's benefit to that. Also, I think sometimes we get wrapped up in treating the individual substance, and with her using different substances. It may just be like the addiction itself, and that behavioral piece. And like if it's polysubstance use, it's she may not care whether it's opioids or methamphetamines or THC, maybe whatever's available to shut her down.
So you're very much looking at the function that the substance abuse is serving. And is this some sort of perhaps maladaptive coping skill that is pluripotent and she'll go to whatever substance is available?
And in that instance, recovery would be important, and those pieces like 12-step programs, practice recovery principles.
Excellent. Thank you.
Thank you.
And then there's mention of a friend she's living with contributing to other drug use.
You know, I can't comment on that. I don't know what that situation is. I know she's kind of moved from friend to friend's houses, and so she's not living in her car. The mental health center is working to try to help her find a place. I know that that's been something that's been in the works.
And I'm just curious, this is Alyssa, by the way, is she, since you mentioned that her, she doesn't have custody of her children, is Child Protective Services involved?
Not that I know of. I think since she was living in her car, they're living with their dads. And as far as I know, they're like 11, 13, and 17. And I know she just doesn't have much relationship with them at this time.
And I used to work in corrections, so I would see that a lot with that population, and it does sound like some polysubstance use, but like co-occurring as well. And that's why I asked the question for, you know, with her job, I saw that a lot in a waitressing field, whether they're working night shifts or anything else, that they kind of gravitate more towards a stimulus because that's kind of a drug that's more frequently involved in that type of atmosphere. And then just my next question, I guess, would be like, have you guys identified like the drivers to her use of, you know, is she numbing something out? Is she covering up a pain? Does she want to feel stimulated and stay up for work? Or I guess, what does that look like?
Those are all valid questions. We talked about the PTSD quite a bit. I forgot to mention that we did start her on an SSRI and have escalated the dose over the last month. So she is feeling her mood is a little bit better. And I haven't nailed down the drivers as to what's causing the use.
Does she have things that she's replacing the drug use with? Like what's her recovery stuff? What is she putting back in? What's the point of being sober?
Right, exactly. She I know she's working a lot, like 10, 12-hour shifts. And she works, I think, to have something to do.
Do you think work could also be a trigger?
Yeah, I do think so.
I mean, I would totally go back to using if that was all I had to look forward to. I mean, I don't know if she's working toward like getting her, you know, or some visitation with her kids or feeling better about herself or whatever her motivations are.
She is applying to school, to the community college. So that's something she has on the horizon that she wants to start.
So we're acknowledging, sorry, go ahead.
Oh, I was just going to ask, do you know where she is in the process of actually getting her kids back? I mean, it sounds like since they're not really under the age of 5, it's not going to be an expedited case, but like, is it, and then there was an assault with one of her children, is it something that she has visitation and it's surrounding like visitation or anything like that?
No, I don't really know. She's very difficult to get information out of. And so that's a good question. I don't know when she even last saw them. I've been working with her for about 6 weeks, weekly. So still trying to get info from her.
I have a question. Are you able to, like, do you have open communication with the mental health center there that she's going to? Okay. Because with somebody in her case who has gone such a long time, it definitely sounds like the polysubstance abuse needs to be addressed because she knows she's doing it. And it obviously coping skills seem like a huge to do. So I don't know how big of a plan you guys could create together. Because you don't really want it to come across like you're bullying her, but at the same time, like we are all on the same page and we have your back. So, you know, tell us what you really want. And if it's mediocre sobriety, then it's mediocre sobriety. But if it's full sobriety in these steps, like these are our short-term goals, these are our long-term goals. But she definitely sounds like coping is her next big thing that she really needs to start working on. But
yes, I agree.
Yeah, it sounds like there's a lot of cognitive dissonance because on one end she's saying, you know, I'm at a level 10 of wanting to get sober, but what she's exhibiting is like living in the world of pre-contemplation, almost like she can see it, but is not really having a fluid plan.
Yeah.
And unfortunately with waitressing too, I mean, I think it's a little sick and unreal to how much we are not aware of all the different kind of drugs that cycle through that. I mean, I've had family work as kitchen managers that just go, I never thought I would ever have to deal with this. But yeah, so that's, if she's increased her availability, unfortunately, with her job, maybe she could consider a different position. Maybe it's a coffee shop instead of waitressing, or just a different environment.
Some wonderful concerns are being brought up when it comes to really what incentives, what disincentives does the patient have prompting certain behaviors, what the function of the substance use is, what purpose does it serve within her life, and also talking about external versus internal motivation, what the patient has at stake. Some great concerns people are thinking through. And it's worth acknowledging one of the things that Megan is working toward is implementing a treatment team model with the mental health center where she's seeing this patient, really to have an open discussion and collaborate with the LAC and everyone else engaged in the patient's care.
I feel like we all should be saying that too, Megan. Good job, because that's hard. And the fact that you've had her for 6 weeks and mostly compliant, basically, you're awesome, because there's a lot of providers that don't even want to touch it. So thank you for what you're doing.
Thank you.
All right, so we got the evaluation link. Please remember to use the continuing education link, as Amber will not be doing it this time around, for those who don't click it. Any closing questions in our last few minutes?
I do want to remind people too, earlier in the chat, I put in the link if you want to submit a case. So we are actively searching out cases, and the cases don't exactly have to match the didactic content. So don't worry about making sure that you're doing one that specifically fits topic XYZ. Just submit a case that's interesting, maybe one that you have some questions about, and so that you can receive feedback like what we just discussed.
Megan, would it be okay if we touch base with you in a few weeks to ask for an update?
Yes, of course.
Awesome. Wonderful. Well, thank you, everyone. Great discussion. Really appreciate it. Hope everyone has a great rest of their week.